So I want to thank the organizers of the meeting for giving me the opportunity to present virtually today. My name is Peter Voorhees. I'm a professor of medicine at Levine Cancer Institute at Atrium Health, and I'm going to be talking with you today about the treatment of newly diagnosed transplant-eligible multiple myeloma. So let's start off with a case. The patient is a 60-year-old woman with type 2 diabetes mellitus who presented to the emergency department with progressive left-sided chest pain over 3 months. Cardiac workup was negative. A chest CT demonstrated a large lytic lesion involving the left fifth lateral rib with soft tissue extension. Numerous lytic lesions were seen throughout the thoracic spine, other ribs, and sternum. Further workup revealed a diagnosis of revised ISS stage 2 IgG kappa multiple myeloma. The creatinine was 1.3. Myeloma FISH testing was positive for a gain of 1Q. The 1114 translocation, and several other trisomies. The patient has baseline neuropathy attributed to her diabetes with associated burning pain for which she takes duloxetine and gabapentin. So what is the optimal induction therapy for this patient? And I will say right from the beginning that there may be more than one right answer here. I've listed a couple of different doublets, lenalidomide or bortezomib with dexamethasone, a couple of different proteasome inhibitor cyclophosphamide-based triplets, VCD and KCD, a couple of different len-dex proteasome inhibitor triplets, RVd versus KRd, and then the addition of daratumumab to RVd or KRd. Let's talk about optimal triplets. So should we be using an IMiD or cyclophosphamide in combination with proteasome inhibitor and dexamethasone? And the first group that looked at this was the IFM group, which basically looked at bortezomib thalidomide and dexamethasone versus bortezomib cyclophosphamide and dexamethasone for transplant-eligible multiple myeloma patients. And what they showed is that the depth of response, as assessed by very good partial response or better, was higher with the proteasome inhibitor IMiD triplet compared to the bortezomib cyclophosphamide triplet. The side effects were as you would expect with the individual agents. So there was more hematologic grade 3 or higher toxicity with the cyclophosphamide-based triplet, whereas there was more grade 3 or higher neuropathy with the IMiD-based approach. And stem cell collection was feasible in both groups. Similarly, a more recent trial, the FORTE Trial, looked at this particular question in the context of carfilzomib-based therapy. So this particular randomized phase 2 study is actually looking at a number of different questions, but one of the initial questions, is there a difference in response for those patients that get induction therapy with carfilzomib cyclophosphamide and dexamethasone or carfilzomib lenalidomide and dexamethasone? And what you can see here is that the very good partial response rate and better clearly favors the KRd arms of the trial compared to the KCD trial. And when you look after when you look at after consolidation, which you can also see here too, is that there's an improvement in stringent CR rate with the KRd arms of the trial compared to the KCD arms of the trial. So it's clear here that lenalidomide instead of cyclophosphamide improves depth of response. This was also seen with the MRD data presented for this trial as well. So to conclude this portion, it's clear that IMiD proteasome inhibitor dexamethasone triplet combinations are associated with greater depth of response than a cyclophosphamide proteasome inhibitor dex combination. But there's no data on longitudinal outcomes. So I would argue that for those patients that do not tolerate IMiDs or cannot afford them and have significant financial hardship with IMiDs, that a cyclophosphamide proteasome inhibitor dexamethasone combination is a good option for that group of patients. Now, bortezomib or carfilzomib in the newly diagnosed setting, this should be pretty obvious, right? So the ENDEAVOR trial was a phase 3 study that was conducted in patients with relapsed multiple myeloma who had received 1 to 3 prior lines of therapy. And patients were randomly assigned to either bortezomib and dexamethasone or carfilzomib and dexamethasone until disease progression or the development of unacceptable side effects. And what you can see here is that the overall response rate with carfilzomib and dexamethasone was better. The depth of response clearly favored carfilzomib, and this translated not only into a very notable improvement in median progression-free survival, but a difference in median overall survival as well, that was statistically significant. So it's pretty clear carfilzomib is the better proteasome inhibitor, correct? So what do we know about KRD, or carfilzomib, lenalidomide, dexamethasone, in the newly diagnosed setting? And I want to highlight a study that was conducted by the MMRC and that was recently published in Blood just a short while ago. This was a study where they gave 4 cycles of KRD induction therapy prior to transplant. Upon recovery from transplant, they got 4 cycles of consolidation KRD therapy. They then went on to 10 4-week cycles of combination maintenance therapy, and then they went on lenalidomide maintenance until disease progression or the development of unacceptable side effects. And what you can see here, as you go from the end of induction to the end of transplant to the end of consolidation to best response, you can see unprecedented depth of response to the point where we're at post-consolidation. 90% of the patients have achieved at least a very good partial response, and 6 out of 10 patients have achieved a stringent complete response. When you go beyond post-consolidation into maintenance therapy, you see the stringent CR rates rise to 76%, which is really quite remarkable. This particular approach also performed well in patients with high-risk multiple myeloma. So 5-year progression-free survival for those with high-risk cytogenetics was an impressive 57%. Now, that was not as good as the 81% for those with standard risk cytogenetics. Nonetheless, the 57% at 5 years is really an unprecedented result, with 5-year overall survival in that same group of patients of 72%. So very promising. So now let's flash forward to the Endurance trial. Now, this was a study that was conducted in a non-transplant setting, but there were transplant-eligible patients that were participating in this particular trial. And this was a study that basically randomized patients to either VRd or KRD for a total of 36 weeks. There was a second randomization which assigned patients either to lenalidomide maintenance therapy for a total of 24 cycles or lenalidomide maintenance therapy until disease progression. The primary endpoint of the first randomization is progression-free survival. These are the baseline characteristics of the patients on this trial. This was presented by Dr. Kumar at ASCO back in late May. And you can see that the various characteristics are very well matched. This is the treatment disposition. And I think it's important to note that actually more patients completed the KRD compared to the VRD. There were more discontinuations due to adverse events and complications in the VRD arm compared to the KRD arm. About 25% of patients in both arms, a little more than that, did eventually get stem cell transplant. And what you can see here is that when you look at very good partial response or better, there is a better depth of response in the KRD arm compared to the VRD arm of this particular trial. However, this did not translate into an improvement in progression-free survival, nor did it translate into an improvement in overall survival as well. When you look at specific adverse events, not surprisingly, when you look at the composite adverse endpoint of cardiac, pulmonary, and renal toxicity, there was a clearly higher rate in the carfilzomib arm compared to the bortezomib arm, which is as expected. And when you look at it as far as grade 3, 4, and 5, again, more cardiac, pulmonary, and renal complications of higher grade severity in the carfilzomib arm compared to the bortezomib arm. On the flip side, and again, not surprisingly, there was a much higher rate of neuropathy in the bortezomib arm compared to the carfilzomib arm, and this includes patients with higher rates of grade 3 peripheral neuropathy with bortezomib relative to carfilzomib. So I would conclude that there is no clear winner with regards to efficacy in newly diagnosed multiple myeloma with regards to bortezomib versus carfilzomib therapy. But one important question, are these greater depths of response with KRD achieved faster, which is a relevant question in the transplant context. But I think largely we need to base our decisions about these two different triplets on toxicity profile. So for our case, for example, a patient with pre-existing neuropathy, we may want to go with KRD in that case. but somebody who has pre-existing cardiopulmonary or renovascular disease, bortezomib-based therapy may be the better option. I do think that the data from the MMRC trial are very positive, but I think, and particularly in high-risk patients, as I mentioned before, but a lot of this has to do not just with the fact that they used carfilzomib rather than bortezomib, but they used a very aggressive approach of induction, post-transplant consolidation, and multi-drug maintenance therapy before moving on to lenalidomide monotherapy as their maintenance. Now let's go ahead and talk about proteasome inhibitor IMiD-based triplets versus quadruplets, where we're adding an antibody into the triplet backbone. So we have the CASSIOPEIA trial, which is a phase 3 study that looked at bortezomib, thalidomide, and dexamethasone prior to transplant, with or without daratumumab, after recovery from stem cell transplant. So patients got 4 cycles of induction therapy, they got transplanted, they got 2 cycles of consolidation therapy, and then there was a second randomization, and this is important, to either no maintenance therapy or maintenance therapy with daratumumab for every 8 weeks up to 2 years. And the primary endpoint was stringent complete response rate, with secondary endpoints including MRD, progression-free, and overall survival. Now, the GRIFFIN study is one that I led, which is a phase 2 study similar in construct to the CASSIOPEIA trial, with an important couple of differences. So we looked at RVd as the backbone therapy with or without the addition of daratumumab. So patients, again, received 4 cycles of induction therapy, like in the CASSIOPEIA trial. They then went on to stem cell transplant, 2 cycles of post-transplant consolidation, but there was not a second randomization. Instead, those patients assigned to RVd received lenalidomide maintenance therapy, ideally until disease progression or the development of unacceptable side effects, whereas those assigned to the Dara arm got daratumumab plus lenalidomide for the first 2 years, followed by lenalidomide maintenance therapy, monotherapy thereafter. And our primary endpoint was the same as the CASSIOPEIA trial, stringent CR, with secondary endpoints being MRD, progression-free, and overall survival. The MASTER trial was a study that my colleague, Dr. Luciano Costa from UAB, presented at ASH, which is looking at the daratumumab-KRd regimen for patients with newly diagnosed transplant-eligible multiple myeloma. And this is a neat study where they used induction therapy with Dara-KRd, tested for MRD. The patients then got transplanted, again were tested for MRD. Now for those patients that were MRD negative at 10 to the minus 6, or sorry, 10 to the minus 5 twice, they actually go onto observation. For those that are not MRD or MRD negative for the first time after transplant, they get consolidation Dara-KRd for 4 cycles and are retested for MRD. And again, if you've had 2 consecutive MRD negatives, you go to observation. If you are still MRD positive or MRD negative for the first time, you get 4 additional cycles of Dara-KRd consolidation therapy, again getting tested for MRD testing. And for those that remain MRD positive, they then go on to lenalidomide maintenance therapy, whereas those that have sustained MRD negativity, as defined by 2 consecutive MRD negative results, again, they go on to treatment-free observation. So what do we have here? So what you can see here in these first 2 rows, as you go from induction to transplant to post-consolidation, you see an increase in depth of response over the course of time. And not only that, but you see a clear difference in depth of response for those that receive daratumumab. So if you look at stringent CR, approximately 29% versus 20%. If you're looking at greater than or equal to VGPR, 83.5% versus 78%, and a very clear difference in MRD negativity, at least at a 10 to the minus 5 level, of 62% versus 43%. Similarly, in the GRIFFIN trial, our results were almost identical with regards to the CASSIOPEIA trial. So by the end of consolidation, the stringent CR rate was 42.5% in the Dara arm compared to 32% in the RVd arm. We also saw an increased rate of very good partial responses and better, and a clear improvement in MRD negativity. And in Luciano Costa's Dara-KRd trial, by the end of consolidation, they're reporting an unprecedented 95% stringent complete response rate, everybody in very good partial response or better, and 82% of patients being MRD negative, recognizing that it is a single-arm phase 2 trial, but very impressive initial results. So one of the issues with the CASSIOPEIA trial is that while they did see an improvement in progression-free survival associated with this improved depth of response, the data are confounded a bit by the fact that there is a second randomization to daratumumab maintenance or observation. And as you can see here, the progression-free survival curves really start to split right around the time that maintenance therapy would be introduced. So this really begs the question, how would VTD followed by daratumumab maintenance therapy compared to the incorporation of daratumumab into the induction followed by daratumumab maintenance therapy? And I think we'll have to watch this study very closely and see the results from the second randomization to help us better understand that question. Now, we know that the use of lenalidomide maintenance therapy until disease progression is associated not only with a notable improvement in median time to progression, but an improvement in median overall survival as well. So in many parts of the world, and certainly in the United States, most of us are using lenalidomide maintenance therapy until disease progression for those patients that can tolerate it. And that is exactly why we use lenalidomide maintenance until disease progression in the GRIFFIN trial. And this may be why we have not yet seen an improvement in progression-free survival in the GRIFFIN trial like we did in the CASSIOPEIA trial. So you can see here from a PFS perspective, both groups are doing incredibly well. And similarly, at the 24-month mark, overall survival is 96% for those in the Dara-RVd arm compared to 93.5% for those in the control arm. This does not come without a cost, so adding daratumumab into the regimen is associated with an increased rate of grade 3 or higher neutropenia. It is associated with a higher incidence of overall infection. However, thankfully, it is not associated with an increased rate of high-grade infection, very similar between the experimental and control arms in both studies. There is an impact on stem cell yield. So there were fewer stem cells collected in the Dara-VTD arm. These two cells here are actually flipped around. I apologize about that. But there was a lower median stem cell yield in the Dara-VTD arm. And similarly, there was a lower stem cell yield in the Dara-RVd arm. And while that may not be clinically significant, it is a difference that's statistically significant. And I would also add that there was a higher use of plerixafor when daratumumab was part of the regimen. So that does need to be considered when we're thinking about costs. And speaking about costs, not surprisingly, when we start looking at these 4-drug regimens, we're looking at unprecedented cost of therapy. And I think that this is going to need to be taken into consideration as we're deciding, what optimal therapy is for patients going forward. So to summarize this portion of my talk, I would argue that the addition of Dara to an IMiD PI-DEX backbone improves depth of response in the transplant setting. The addition of Dara to the VTD backbone also improved progression-free survival. But again, these results are confounded by the second randomization to maintenance or no maintenance therapy. The addition of Dara to the RVD backbone in the transplant setting has not shown an advantage in PFS to date. However, studies with daratumumab in the past that have been associated with better stringent CR rates and MRD negative rates have invariably been associated with improvements eventually in progression-free survival. But the question does come up, will lenalidomide maintenance to disease progression in the control arm negate a PFS advantage that would otherwise be seen with better depth of response in the Dara arm? And we'll need longer follow-up to really know the answer to that question. The addition of daratumumab to any IMiD proteasome inhibitor DEX backbone has yet to demonstrate an overall survival advantage, but we're obviously going to need much longer term follow-up to really look at that question. So I would say consider a quad in transplant eligible patients, but early adopters need to keep an eye on the results of the GRIFFIN study, as well as the randomized phase 3 Perseus trial, to ensure that this improvement in depth of response translates into a benefit with regards to longitudinal outcomes. And also, it's very important that you collect stem cells after 4 cycles, as Dara does have some impact on mobilization. So going back to our case, what is the optimal induction therapy for this patient? I would argue KRD based on their underlying peripheral neuropathy. And with that, I'll end. Thank you very much for your attention.